Well, that study was really looking at a couple of different things. It was looking at biomarker-driven, whether cancers with gastric esophageal cancer, esophageal cancers, how to select patients, the most appropriate patients for immunotherapy. So it was looking at the metastatic setting, as well as then some of those earlier stage studies which I just spoke about. But what are the take-home messages? Well, we now know in gastric cancer there's two specific subsets that look more promising for response. Those patients who have Epstein-Barr virus-driven gastric cancers, or patients with microsatellite instability or mismatch repair deficiency. So how many patients have those particular underlying tumor biologies? Well, about 9 to 10% of patients globally, they're gastric cancers or EBV related. And anywhere, I mean, the figures for MSI are all over the place really, but it looks like it's probably less than 10%. We just saw some data just in the last hour from a large 259 patient study for Pembrolizumab. They only saw about 4 to 5% of the patients were MSI positive. So those patients are responding very, very well to either Nivolumab or Pembrolizumab. But the next generation of trials really are combination studies, looking at combining more than one immunotherapy drug. And so that's where I think most of the benefits will happen in patients who are PD-L1 negative or don't have those specific two particular types of a gastric cancer. So what we see now is multiple trials in esophageal cancer and gastric cancer, looking at combination studies in patients who are both PD-L1 positive, which means their tumor is expressing the programmed death ligand 1, or patients who are negative. And hopefully what we'll see is patients in both groups will respond to combination therapy a little bit better than what we're seeing with single agent. What are the response rates to single agent therapy right now? So in the heavily pretreated patients, in the second or third line setting, if the tumor is PD-L1 positive, we see response rates of the order of anywhere between 20 to 25%. If the patient's tumor is negative for PD-L1, it's slightly lower, it's more like 10 to 12%. So there is a biomarker there, PD-L1, but it's not a perfect biomarker. The hope is the next couple of years we'll see better ways to select and then give more drugs rather than just one drug to really improve the efficacy in those patients with difficult to treat tumors.